Hi, my name is Shannon Connors, and I did my behavior change project on increasing the vocal means of an early learner through the use of leveled prompting and functional communication training. My learner was a 2-year-old boy with an autism and expressive language disorder diagnosis and a possible apraxia diagnosis as well. He was diagnosed at 19 months old at a local children's hospital. He took part in the state's early intervention services for speech therapy, occupational therapy, and developmental therapy. However, his parents did not feel that was quite intensive enough, so they brought him to our clinic. He's there now for 20 hours a week due to his age. He is an only child and lives with mom and dad at home. The behavior that brought him to us was, as I spoke before, the minimal expressive language that he has. He communicates through minimal signs, grunts, pointing, bringing items to adult, or an adult to an item. He does have a strong receptive repertoire and emerging mimetic skills that we are using for this communication training. The target behavior was identified as any audible sound or combination of sounds that closely approximate an actual word. They have to include either a beginning or an ending sound, and we worked closely with a speech and language pathologist to identify sounds that he could physically make, and we put those in as what would be an acceptable response. We also required it to be heard by more than one individual, so an untrained listener could also hear. The measurement that we used was a frequency count, and it was based on the leveled prompting levels 1 through 4, which I will explain further in a few minutes. And data was collected for 1 hour per day for each session, and it was either the first or the second hour that he was there of the 4 hours that he is in the clinic. This allowed us to track articulation, motivation, and independence. The design that we used was an AB-AB reversal, and it just allowed for a clear correlation of the intervention and the increased vocal meanding. The baseline, to begin with, before we even started, we gave him a formal preference assessment with several different items, and it helped us to track 12 targets that we used for the intervention. And then these items were placed on restriction, so he did not receive them. There was zero access at home, at the clinic, anywhere else, so that the motivation would be even higher. These desired tangibles, or there were edibles as well, were made visible to him during baseline. Just free reign, here you go. And when he would point to one and say that he wanted it, through any way that he said it, the instructor would then pair it with the actual word. So if he pointed to juice, we'd say, yep, juice. Or if he handed the card that said pretzel, awesome, you want a pretzel? Here you go. And it was delivered immediately. This was completed by an RBT along with either a program manager or the SLP as a second listener. And training was offered to all involved before every new condition. So the baseline data was collected over 5 sessions. The intervention, as I mentioned before, we placed 3 to 5 different options in front of him, within 2 feet of him, but 3 to 5 inches apart. And the clip art piece was laid in front of all of them. And if a learner showed any desire at all for them, pointing, grabbing the card, whatever it was, then the prompting sequence would begin, and the therapist would start with, what do you want? If the child responded immediately, great, it was given differential reinforcement. He was given 5 seconds to respond before the SD was repeated, and that would be up to 3 times repeated for each prompting level. So if within that first 3 times being said, he responded with juice, or an approximation for it, it was delivered, social praise was given, tickles, loves, hugs, whatever it was that just really excited about. If in that time he did not, it moved to the next one where it was repeated again. What do you want? Juice. So they would then give him the word. Again, with the 5 seconds and the 3 times, successful, he gets the item and just a little bit less of the extra reinforcement. If he didn't get it right there, we would reprompt it again. So we would say, what do you want? Oos. So whatever the approximation is that we would take is what we would give to him then. Same sequence, he had 5 seconds and 3 attempts. If he did not do it there, it went to prompt level 4, at which point the item was removed, and we would just say, hey, nice trying that you asked for juice, and we would start a new trial. IOA was collected as a trial-by-trial basis with an unfamiliar listener, so a different program manager or the speech and language pathologist that was in once a week. It was collected for 10 minutes each intervention session for reliability, with 95% accuracy and baseline and 97% in the intervention phases. There were also fidelity checks completed by the BCBA 2 times per week with a 98% accuracy rate. The results were that, and I have my graph right here if you can see it. In the baseline, it was a mean average of 5.8 vocal bands. Intervention, the first intervention phase, went to 16.6. The return to baseline fell very briefly to 16.4, and then the return was, the average was back up to 24, so that was really exciting for us to see. The generalization, we had 2 therapists that were direct care therapists with him, along with a program manager and BCBA that would come in to do the fidelity checks. These were also targeted at home, and we will continue that through the intervention because we are now introducing a home program to him, so that will be continued. The functional communication training, what we found here is functional communication training can actually increase the vocal bands, as we've seen in this learner. However, there are limitations, and that is that this was a single subject, so it pertained to him, but we don't know what it would do for other learners. Also, the leveled prompting and the picture card selection, they were not tracked separately, they were tracked together, which leads us to wonder if it was a combination of the 2 that increased the vocal bands or one versus the other, so that definitely is something that would need to be addressed in the future. Also, spontaneous bands that were outside of those target bands were not tracked for this study. So definitely has some limitations, but I feel like we had a solid correlation between the functional communication training intervention and the increased vocal bands.